Today I'm going to talk about coronary artery occlusion from Kawasaki's disease. As a definition, we have that Kawasaki's disease is an acute idiopathic self-limiting vasculitis that primarily affects children. Clinical features include fever, non-exudative conjunctivitis in both eyes, mucositis, cervical lymphadenopathy, polymorphous rash, and changes in the hands and feet.
The other type of medium-sized vasculitis is Kawasaki disease. Kawasaki disease is an uncommon systemic vasculitis disease affecting mainly children under the age of 5. Kawasaki disease is a medium-sized vasculitis. Kawasaki disease and Hinoch-Schönlein purpura are the most common primary vasculitides in children. It is more prevalent in Asians and native Pacific Islanders, and is a leading cause of childhood acquired heart disease in developed countries, which include coronary aneurysms. The exact cause of Kawasaki disease is unknown, but clinical and epidemiological data support an infectious cause. In Kawasaki disease, an intense inflammatory cell response develops in a wide array of organs and tissues in medium-sized arteries such as the coronary arteries. The pathophysiology of Kawasaki involves monocytes, IgA antibodies, neutrophils in the acute setting, and cytotoxic T cells. These guys all play a role in the inflammation of the medium-sized vessel. What is thought to drive this temporary vasculitis is an infection. Theories include Staphylococcus and Streptococcus species, such as from strep throat, and even a viral infection. Antigen-presenting cells will pick up these antigens and mount an inflammatory response. The inflammatory response somehow misdirects the attack and will attack the medium-sized vessels temporarily, and this includes the coronary arteries. This response can damage collagen and damage elastic fibers in the vessel walls and can lead to loss of their normal structural integrity. Despite the repair that occurs, the disrupted structural integrity results in ballooning or aneurysm formation. The clinical features of Kawasaki is usually a child less than 5 years old with high fevers for more than 5 days and irritability. Some classic findings in Kawasaki can be remembered with the abbreviation CREAM. C is for conjunctivitis, bilateral non-purulent. R is for rash, polymorphous or maculopapular rash. E is for erythema and or edema of the hands or feet. A is for adenopathy, lymphadenopathy, specifically in the cervical chains. And M is for mucous membrane changes, which include red tongue, strawberry tongue, and dry, cracked lips. The diagnosis of Kawasaki is made if the child has 4 of the 5 following letters in CREAM, as well as having a fever for more than 5 days. For children who present with a purpura or a particular rash with fever, the differential is broad. A good start is to divide differentials into thrombocytopenia and non-thrombocytopenia-induced rash. But some important differential diagnoses to remember include measles, where there is evidence of exudative conjunctivitis, Koplik spots, and rash, which tend to occur in the head and migrate to the trunk. Drug reaction is an important differential, which leads to a generalized rash eruption all over the body, usually itchy, and another important feature is the angioedema, which is swelling. Infections is a fundamental differential and includes Streptococcus infections. And remember, infections are associated with the development of Kawasaki. So for example, Streptococcus pharyngitis. And Streptococcus pharyngitis can then also lead to scarlet fever. Streptococcus pharyngitis can also lead to rheumatic fever, an autoimmune response to the Streptococcus infection. Another differential are the Staphylococcus infections, which typically include the skin. and is also associated with the development of Kawasaki disease. Staphylococcus infection differentials include Staphylococcus scald skin syndrome, which is characterized by red, blistering skin that looks like a burn. Another is toxic shock syndrome, which is caused by the release of bacterial toxins from the Staphylococcus species and is associated with tampon use. Another important differentials and also potentially the trigger for Kawasaki are viral infections, which can also manifest as a maculopapular rash. Finally, a very life-threatening differential is Stevens-Johnson syndrome. Investigations to order include a full blood count to look for signs of infection, EUCs for kidney involvement, LFTs to look for viral causes affecting the liver, CRP and ESR, which are inflammatory markers. These should be high in Kawasaki, as well as in infections. Urinalysis is good to look for evidence of increase in white cell count. Finally, it is suggested that an echocardiogram should be performed once the diagnosis of Kawasaki disease is made, as well as 6 to 10 weeks after, to check for myocardial inflammation and coronary artery aneurysm formation. Remember, the main complication of Kawasaki disease is coronary artery aneurysms, but it is not uncommon for aneurysms to occur anywhere along the branches of the aorta. Once diagnosis of Kawasaki is made, it is essential that a pediatrician is involved. Admit the child and commence immunoglobulin intravenously as well as aspirin. Commencing intravenous immunoglobulin within 10 days of fever onset has shown to reduce cardiac complications. The complications of Kawasaki are mainly cardiovascular and include coronary artery aneurysms, as well as artery aneurysms anywhere else, myocardial infarction, pericarditis, and myositis. Thank you for watching. That concludes the video on medium-sized vessel vasculitis.
As applications in medical English, for epidemiologic surveillance, CDC defines a case of Kawasaki disease as illness in a patient with fever of 5 or more days of duration, or fever until the date of administration of intravenous immunoglobulin if it is given before the 5th day of fever, and the presence of at least 4 of the following 5 clinical signs, which are rash, cervical lymphadenopathy at least 1.5 in diameter, bilateral conjunctival injection, oral mucosal changes, and peripheral extremity changes.
The coronary arteries are the blood vessels that supply oxygen to the heart muscle. Because the heart muscle is always contracting, it needs a steady flow of blood to bring it nutrition and oxygen. When children develop Kawasaki disease, the walls of these arteries become inflamed. If we could go inside the blood vessels, we might see something like this. Normally, a cell layer called the endothelium protects the vessel wall and prevents blood cells from leaving. However, some trigger during the development of Kawasaki disease causes the endothelial cells to become activated and causes cells of the immune system to stick to the endothelium and leave through the blood vessel wall. Inflammation in the vessel wall is caused by immune cells gathering in the wall and liberating chemical signals that recruit more cells and further damage the vessel wall. Intravenous gamma globulin, or IVIG, interacts with these cells to quiet down the immune response, although the exact mechanism of how this is achieved are poorly understood. When inflammation occurs in the vessel wall, it causes the artery to dilate. About 1/3 of children in the early or acute stage of Kawasaki disease will experience dilated or widened coronary arteries. If the patient is treated with a protein solution called gamma globulin, or IVIG, within the first 10 days after fever onset, the chances of the dilated artery returning to normal size without scarring are excellent. However, if the inflammation is treated late, or the IVIG infusion is not effective, permanent damage can occur to the arterial wall. Sometimes this results in a ballooning out of the wall, called an aneurysm. This ballooning of the vessel causes the blood to swirl and increases the risk of blood clot formation. If the blood clot continues to grow, this may result in blockage of the vessel and a heart attack. In many cases, scar tissue will begin to form in the aneurysm over time, and the blood vessel will heal. However, the blood vessel is never again completely normal, and many years after Kawasaki disease, scarring could lead to narrowing of the vessel and again present a risk for heart attack.
As to the pros and cons, in the continental United States, population-based and hospitalization studies estimate an incidence of Kawasaki disease ranging from about 9 to 20 per 100,000 children under 5 years of age. In the year of 2016, approximately 5,440 patients or hospitalizations with Kawasaki disease were reported among children under 18 years of age in the U.S. 3,935 of these children were under 5 years of age, for a hospitalization rate of 19.8 per 100,000 children in that age group.
The coronary arteries may be affected by Kawasaki disease. Just as you see red rash and red eyes, this is just a marker of soreness in all the blood vessels in the body. The coronary arteries, the arteries to the heart, are also blood vessels, and so they can be affected by the inflammation of Kawasaki disease. A coronary artery aneurysm is where a particular coronary artery has got a swelling in the middle. This means instead of being a nice fine tube taking the blood to the muscle of the heart, it's become inflamed and sore and swollen, and this can interrupt the blood flow of the muscle to the heart if it causes a clot, for example, in that particular area. So much of the treatment is aimed at damping down that inflammation to reduce the tendency of the aneurysm to occur, or if it has already occurred, in order to minimize that swelling, to minimize the damage to the heart muscle.
As to the issue applied in Ecuador, it is a very rare disease, not very common here in Ecuador. Treatment is similar as proposed in the clinical case. And as to the conclusion, because not all these features are necessarily present and there is no specific diagnosis test for Kawasaki disease, the diagnosis may be missed in childhood or occurs at such an early age that the adult patient has no recollection of illness. Affected children are at risk for cardiovascular complications, such as presented in this case. Thank you very much.